All right. Okay, hello, and thank you everyone for joining us. The Southeast Mental Health Technology Transfer Center is very pleased to present today's webinar event, Using Technology to Improve Access and Quality of Child Mental Health Care. My name is Emily Moore, and I will be moderating today's webinar event. Joining me in introducing our center, as well as today's speakers, is Dr. Benjamin Druss, Director of the Southeast MHTTC. Just to let everyone know who is participating, this presentation will include poll questions. Whenever you see a poll question like this appear, please review the question and follow the instructions to submit your answer. The poll questions today are either yes or no questions or multiple choice. Please make sure that you visit our Southeast MHTTC's website at mhttc.org/southeast. Again, that is mhttc.org/southeast. On our website, we are currently inviting mental health providers and clinicians from across the region to share their COVID-19 related stories. Southeast Stories is a new initiative that invites the mental health workforce from across the region and beyond to share highs, lows, struggles, and strategies in continuing to provide mental health services and care during the COVID-19 pandemic. Please feel free to visit our website to share your own story. We would love to hear from you. Dr. Druss is now going to take a moment to describe the work of our center and to introduce today's speakers.
Thank you, Emily. Hello, everyone. I'm Dr. Benjamin Druss, a professor of health policy and management and the Rosalind Carter Chair in mental health at Emory University, as well as the director of the Southeast MHTTC. We want to thank you all for joining this important and very timely presentation. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at the Rollins School of Public Health at Emory University. We are proud to serve the 8 states in HHS Region 4, Alabama, Florida, Georgia, Kentucky, Mississippi, North Carolina, South Carolina, and Tennessee. Our goal is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance throughout Region 4. We encourage you to visit our website, mhtttcnetwork.org Southeast, to learn more about our center and upcoming events. Now, I'd like to introduce our speakers for today. Dr. Ken Ruggiero is South Carolina's Smart State Endowed Chair and Professor of Nursing and Psychiatry at the Medical University of South Carolina. He directs the Technology Application Center for Healthful Lifestyles and Trauma Resilience and Recovery Program. He has led a number of population health initiatives designed to leverage technology to improve access and quality of care for vulnerable and traumatic stress populations, including traumatic injury patients, disaster survivors, children who have experienced abuse and neglect, and firefighters. Dr. Margaret Anton is a postdoctoral fellow and licensed clinical psychologist in the College of Nursing at the Medical University of South Carolina. Her research broadly focuses on the use of digital technology to improve access and quality of youth mental health care. She is interested in understanding how to improve the implementation and sustainability of technology-enhanced interventions and examine the impact of those tools on broader mental health service delivery. Welcome, Dr. Ruggiero and Dr. Anton, and thank you both for being here. We'll turn it over to you.
Thank you very much, Dr. Dross and Emily. Appreciate being here, and thank you everybody who's in attendance. It's great to have the opportunity to talk to you all. I'm gonna pull up my PowerPoint here. Okay, and yes, as Dr. Dross mentioned, we're gonna talk about access and quality of care, and what we'll do is, let me see if I could figure out how to, there we go. Advance the slide. We're going to give an overview of some of the work that we've done just to give you a feel for what we're doing to try to improve access and quality of care. Some of the resources we show you may be relevant to some of your patients, others may not be. We'll probably spend about 20 minutes or so, nearly half of our presentation time, to do a show and tell demo, live demo of our iPad toolkit called SPARK, which stands for Supporting Providers and Reaching Kids, which is something that we've developed over a series of projects to provide essentially games and activities that providers can use in care to help them deliver TF-CBT. But I think you'll see from some of the examples that it's applicable to a much broader population than just kids receiving TF-CBT. We'll then, Margaret will talk quite a bit about the state of science in telehealth and essentially how to better serve patients while we struggle with COVID-19, because I know a lot of people have switched to telephone and or televideo based treatment, and so she'll cover some of those bases. All right. So I'll start by talking about a couple of our various initiatives that we're doing. As Dr. Dross mentioned, we're part of the Technology Applications Center for Healthful Lifestyles at the Medical University of South Carolina. And the mission of TACKLE is essentially to leverage technology to improve access and quality of care. And so we have a series of population health initiatives. We've been doing this for many years. And one example of that is Bounce Back Now, which is a self-help intervention that is designed to address the mental health needs of disaster survivors. We know from a lot of epidemiologic research that 5 to 10% of disaster survivors start to develop PTSD and depression, but that a very small percentage of people who do develop PTSD and depression actually get mental health treatment. So the goal in developing Bounce Back Now was to try to bridge that gap and try to improve access to evidence-based resources for disaster survivors who might not be inclined to access care. Now, what the app does do is not just provide some self-help resources, but also tries to create mechanisms to link patients to formal mental health care. It's not meant to replace treatment, because really we've learned over the years that standalone apps and web-based interventions are not a good replacement for professional services. So what we're trying to do is give them a taste of evidence-based skills and resources to practice and use at home, but then to give them some education about how to connect to care. We've partnered with SAMHSA, specifically the Disaster Distress Helpline and American Red Cross in this work, and we've found actually that the resources we've developed have reduced risk for PTSD and depression among adolescents, as well as depression among adults. We're now, I'm going to show you a couple screenshots just to give you a flavor of what that looks like. Oh, I'm not advancing it properly. There we go. So on the left, you see an example of a deep breathing tool where the balloon inflates and deflates at a pace that we would want disaster survivors to use if they're trying to reduce distress in the moment. In the middle, you'll see muscle relaxation, which is a series of audio narrations to describe what to do to try to achieve a more relaxed state. And then on the far right, you see an example of a mindfulness activity. We also have built into the app things like behavioral activation exercises where they can choose and schedule fun and functional activities, and keep coming back to the app to try to increase their engagement in manageable, fun, and functional activities as a way to overcome depression. We have a writing exposure tool embedded within this. So a series of resources that are meant to help disaster survivors. We actually just very recently finished a big trial of 1,500 disaster survivors affected by hurricanes Michael, Florence, um, Harvey, Irma, and Maria. And as a result of having finally completed that study, we are now ready actually to do a national public launch of this. We're needing to revamp a few elements of the app before that actually happens, but we expect that in the spring of 2021, it will be fully nationally launched in both English and Spanish. Another thing we've been doing probably for the last 9 or 10 years, we created the Center for Firefighter Behavioral Health at MUSC, and this has been largely funded by FEMA. And what we've done through FEMA funding is to develop and launch a series of free resources that are designed to provide training to clinicians online. Some of you may be familiar with TF-CBT Web. That was an online provider training course that I was a part of about 15 years ago when we first built it at the National Crime Victims Research and Treatment Center. And so we sort of used that model to create a provider training course called Helping Heroes that's designed to educate providers about how to better serve firefighters and sort of any cultural differences that you might tend to see with firefighter populations versus other types of patient populations that you might see. And we've also developed a series of apps to address mood, anxiety, and stigma, because we know a lot of firefighters tend to face a lot of stigma and don't want to get help on their own. And so they might want to rely on self-help tools. As well as one app that we recently launched that is meant for family members and spouses of firefighters. Here's what the Helping Heroes course looks like. You can take a look at it at cffbh.org, Center for Firefighter Behavioral Health.org. If you are interested in learning a little bit more about how to provide services to firefighters, you can see right at the very top is Firefighter Culture module, which gives education about firefighter culture, and then a series of other modules that talk about different strategies that can be used to address anxiety and depression with firefighters. And then here are a couple examples of self-help apps that we have. One that is meant to teach firefighters what to do if they suspect that a fellow firefighter is experiencing suicidal thoughts or plans. And so it teaches them to ask, care, and then maybe take them to help if they need it. And then also the substance use and misuse is an example of a resource we developed to try to give firefighters more education about how to address alcohol use and substance use. My favorite resource that we've developed for firefighters is actually something called Firefighters Helping Firefighters. And again, all of these can be found at cffbh.org. The goal of this was to overcome stigma associated with firefighters seeking care. And we actually have maybe 2 or 3 dozen firefighters who helped us create a video library, because firefighters, when they are getting some education about mental health and behavioral health, they don't necessarily want to hear it from doctors. They want to hear it from their own peers. And so these firefighters spoke up about experiences they've had with mental health, and grappling with decisions about whether or how to seek treatment, and then what that treatment looked like and what recommendations they would have for other firefighters. So we've found that firefighters really value that resource. It was modeled after the National Center for PTSD's About Face resource for veterans. Finally, the Trauma Resilience and Recovery Program is a program that we have for within our trauma center. And the goal really here is that most trauma centers don't address mental health issues, even though they see patients who have experienced gunshot wounds, very serious car crashes, motorcycle crashes, pedestrians that are hit by automobiles. And that patient population has a very high risk for development of PTSD and depression. But a lot of times these patients get released before getting any mental health continuity of care. And so we created a program at MUSC that leverages technology and uses telehealth, but also text messaging, symptom monitoring resources, and chatbots to do a 30-day screen so that we can keep in touch with patients after they get discharged, track their emotional recovery, and then connect them to telehealth-based treatment if they need it a month or two after their injury. So that's another program that we have stood up at the MUSC for about the last 5 years. We've also been able to partner with 3 other trauma centers across South Carolina that now also have this program. I won't go into too much detail here, but we basically, as part of this model, it's a stepped care model. We meet patients on the floor at the bedside to educate them about emotional recovery. We then track their emotional recovery using a text message tool that helps them sort of monitor their recovery on a day-to-day basis. We then screen them over the phone or through chatbot at 30 days, and then the assessment and treatment comes usually through telehealth. So I want to make sure that I spend a good, 15 or 20 minutes talking about the Spark Toolkit. And what I'm going to do here, and I hope this works well, is I'm going to, I'll give you a couple slides of background, and then I'm going to leave the PowerPoint and go straight to a live demo using the web to show you how it can be used with kids. The goal really here is that we want to put tools in the hands of clinicians who are working with kids to help them stay on protocol after they've received training in a particular evidence-based treatment, but also to help them engage kids. We know that providers often struggle to engage certain kids who might not want to be open about their experiences, whether it be their traumatic event experiences or any anxiety or depression they might be experiencing. And so the collection of games and activities that we've created is really based on that understanding, but also draws from studies in child education that suggest that interactive games and touchscreen learning and video demonstrations tend to enhance child engagement. We also were seeing when we were going into lots of community mental health centers that a lot of providers were experimenting with videos and other types of activities that they were finding online, as well as workbooks that they were bringing into sessions. So we know that providers sort of recognize the value in these types of tools, and that they often try to bring them into session. And so what we did was a series of steps to try to educate ourselves about what providers could benefit from along these lines. And so we interviewed 20 nationally certified experts in TF-CBT to learn where they felt that providers tended to get stuck with engaging kids and staying on protocol. We had an advisory panel of 6 or 8 kids in middle school and high school who gave us guidance along the way. We mocked up all of our activities before we then coded it onto the iPad. We put it in front of 24 local providers to get feedback and inform improvements to our mock-ups. We also put it in front of 21 families who had recently completed TF-CBT. Finally, we developed the full app, did a pilot study with 4 local trauma centers, and we're right now immersed in a large controlled trial with 150 providers and 360 families. So now I'm going to leave the PowerPoint and switch over to, I'm going to click the share screen and switch over to the web so that I can show you. I've already logged in, and the system thinks that I'm working right now with a patient who is 12 years old. So there are examples in here that I'll show you that, let me get this, I don't know how to make that stop happening, but some of the examples I show you will be tailored to older kids, but if I were to have logged in saying that I was working with a younger child, then it would give me some different examples, just to give you an idea about how it's tailored by age. But so let's start with, some of you may be familiar with the What Do You Know game. It was developed many years ago by Esther Deblinger and has been sold on Amazon. And it's basically a deck of cards that helps providers deliver psychoeducation to kids. And so she worked closely with us. We've done this work with Rochelle Hansen, Ben Saunders, and also the developers of TF-CBT, Judy Cohen, Esther Deblinger, and Tony Manarino. And so they worked very closely with us to develop a lot of these resources. I'm going to go, these are all the decks of cards that a provider could choose when working with kids. Let's say that they are working with a kid who has experienced physical abuse. That will then open up a screen where they could sort of scroll through the cards and choose certain cards that they want to ask the child questions from. You can see that there are things like provider tabs that give providers tips along the way about how to respond if they're not sure. So it's meant to provide a little bit of additional real-time feedback if providers might need it. Providers and kids theoretically could take turns asking each other questions and keeping score. So that's another sort of example of how that tool can be used. I'll show you the other thing that we did in version 2.0 of this, which is now being used by the providers, is that some of the feedback we got from providers is that they wanted to be able to create their own cards, and they wanted to be able to choose the cards that showed up in advance. And so we now have built in features that allow providers to do that. The You Are Not Alone activity is another activity where providers can help to really hammer home the point that a lot of kids are experiencing things that are not that far out of the realm of what this particular child is experiencing. I'm sure that many of you have had hard conversations with kids around that, where they just feel like nobody understands them and that other people might not have experienced that. So let's say you have a kid who has experienced physical assault, and let's say that they're very interested in soccer. So you might use a soccer theme, but you could see that there are lots of different themes: classroom, concert, football, movie theater, so on and so forth. So we'll choose soccer, continue, and here's the activity. Imagine you decided to start your own soccer league, but only with kids who have experienced physical assault. There are 20 kids on each team. How many teams could you make? Oftentimes early on in the process, a child might think that they're guessing big, but they might say 1,000 teams, and then later realize that, they need to be guessing bigger numbers than this down the road. But you check my answer and you see the feedback. You could make 582,470 teams. If your league had one game every day, it would take more than 1,595 days before each team had a chance to play. You are not alone. So you see how it sort of makes that point very clearly to children. Again, younger kids would get different examples that are a little bit more simple than that. Okay, so I'm going to show you, I know parenting and behavior management is one of those areas where the providers, sometimes might struggle, and sometimes that's because it's hard to actually get the parent into the session and see them. But other times it's because there's just such limited time that, you can provide education, but to do the education and all of the role plays and then to keep following up, it involves a lot of communication with the providers. So we built some resources that are meant to supplement the work that you're doing and help you deliver some of the skill building that you're attempting to do. So I'll use active ignoring as an example, and this is something where I think it actually might be helpful. This is a 3-minute video, and I think we do have time for me to show you one example of this, so I thought this might be a good example to show you about how the videos unfold for caregivers. So I'm going to try to do this to make it larger and then hit play.
In these videos, you will see examples of parents using active ignoring correctly and incorrectly.
Mom, can you type in a password so I can play games?
Can you hold on a few minutes, Sanaya? I'm trying to fill out this application. As soon as I'm done, I will type in the password for you.
Come on, it'll only take you a few seconds. Please?
As soon as I'm finished filling out this application, I will type in the password.
Come on, it'll only take you a few seconds.
This is why I can't ever get anything done.
Take some time to answer these questions. Talk to a health professional about this if one is available. How did the parent handle the situation? How could they have handled it differently? At the beginning of the clip, the parent did some positive things. She responded directly to her daughter, kept calm, and tried to ignore the behavior at first. However, it wasn't long before she gave in. What did the child learn from this? She learned that she can get what she wants if she is pushy enough. And she learned that mom doesn't necessarily mean no when she says no. Over time, these types of interactions are likely to create frustration and become increasingly negative. The good news is that there are ways to deal with this situation that are healthier for the parent-child relationship. Now let's see another way the parent could have handled the same situation.
Bob, can you type in this password so I can play games?
Give me a few seconds, Sanaya. Let me finish filling out this application, and then I can type in the password for you.
Come on, it'll only take you a few seconds. Come on, Mom. Please. Please.
How did the parent handle the situation? In this video, the parent ignored the child's pushy behavior, not just by staying silent, but also by staying calm and turning her head away. The child was trying hard to get her mom's attention, but mom held her ground. Keep in mind that ignoring doesn't usually work right away. In fact, the child's behavior might even increase before he or she gives up. But over time, ignoring will become more effective if the parent uses it consistently. The child will learn that she cannot get what she wants while mom is actively ignoring, and that it is a waste of their time to keep trying. But only if the mother is consistent when she uses ignoring. If she is not consistent, all bets are off. Another strategy that this parent can use to improve the effectiveness of active ignoring is to praise her child when she shows patience.
Okay, whoops. I thought that was going to help me try that again. Okay, got it. Yeah. Okay, so that gives you an example of the types of videos we created and how we created them. They're meant to be delivered in 45 to 60-second segments with some pausing in between. And this is Rochelle Hansen. Every one of the chapters also gives sort of an introduction. Some of them are by experts, and others are animated videos like this one. I don't think I have time to show any of the animated videos, but they're designed basically to introduce the child to that component of the TF-CBT toolkit, and they're normally about a minute in length. So here's an example of a breathing tool that we can use. It also has some audio narration. Sometimes when I've played this, it comes across choppy, so just be aware that that's not how it appears to a child normally. This is an example of a balloon that reflects what might be happening when a child is anxious. So it's meant to represent anxious breathing.
When we feel stressed or anxious, our muscles get tense and we start breathing faster. Our breaths get quicker and shorter. This balloon will inflate and deflate quickly. Try to follow.
I'm not going to go through all that, but you can see that it inflates and deflates pretty quickly, and then you graduate to the relaxed breathing balloon, where you can see that it is meant to illustrate what pace you should be breathing at when you're trying to relax. So this is a tool that a lot of clinicians use in session as a way to teach a child how to pace their breathing. And it's something that ultimately I think we'd love to build in a mechanism so that providers can send this to caregivers so that children can practice using the balloon at home as well. That's something that we ultimately would like to do. There's also some pieces in here that help with progressive muscle relaxation as well as mindfulness, but I don't have time to show all of these tools. Let me also show you real quickly, we built in tools for all of these chapters to help providers prepare for session as well. We know a lot of times providers are running, from one session to the next, and they might have 1 or 2 minutes to work with, and they know, okay, I'm going to be doing affective regulation with this kid, but trying to wrap their head around, what do I need to cover? What bases do I need to cover? Well, this gives, a quick overview of the bases that you should cover if you're doing affective regulation, gives sort of the major overview, but then some examples of behaviors that you might want to do and activities you might want to do, and then a sort of a series of these, and also how to integrate the Spark toolkit for providers who care to use certain activities or games from that. So those prepare for session tools are available for each part of treatment. This is an example of the 60 seconds feelings challenge. A lot of times you're trying to learn what do they know about feelings and how to label them. And so you can sort of do a 60-second challenge using a stylus or whatever, where I can't really do it very well on a laptop, but a child can write down, you know, different words that describe how people feel in 60 seconds, and then you can have a conversation about that. There are also, here's a list of feelings that sometimes people have. Children can circle which ones they might have experienced at various times in their life, and also write in other examples that they'd like to talk about as well on the right side of that screen. This is probably an activity that the kids may have liked most, even more so than the What Do You Know game. This is feeling charades. So you basically spin the wheel. It ends up on a feelings word. The child acts it out. There's a conversation around that word, including, you know, how strongly have you felt that word? And so here's sort of a thermometer, an intensity thermometer, a discussion about where in your body you might have experienced that emotion. And so you can see how the interactivity is built in there to help providers have that conversation and to help providers engage kids more effectively. I'll give a couple more examples. So cognitive coping is one where this is meant to reinforce what providers are already teaching kids naturally in treatment. So crying is a behavior. So you give the child an opportunity to sort of show the provider that they know. So you drag it to behavior. Mad, if a child felt that, oh, maybe that's a thought, it would pop back on them. Because it's not a thought, it's a feeling, and so you need to drag it there. So this is just an example of a drag and drop tool that I think helps to stimulate conversation around thoughts, feelings, and behaviors. And there are several examples of that in here, so I don't want to take too much time with that. Enhancing safety is basically structured. The What Do You Know game was so well received by providers. It was used in our pilot study an average of 4 times for each child. So we used that type of a model for enhancing safety as well, where we built out decks for cyberbullying, internet safety, peer victimization, okay, not okay touches, personal safety, things of that nature. But it's structured basically in the same way as the What Do You Know game. Let me see, just maybe one more example, and then I'm going to move on. So the trauma narration, one of the things we found in our pilot study, we set it up so that providers could actually do drawing, use a drawing tool on the iPad, but we found that they didn't use it. They still preferred to use paper, basically, and either draw or write with the child. So because of that, instead we revamped it, used sort of a video to help providers teach the concept and why they're doing exposure, but then to give them processing tools to help them track their progress in doing the narrative, and then things like the responsibility pie to help them have conversations around, you know, where to assign responsibility for what happened to them. And so you can, you know, write in names and then, you know, basically color in the responsibility pie in collaboration with the child. All of these things are designed to be tools that help providers connect with kids a little bit more, to reinforce what they're already teaching them, and to help providers stay on protocol. So I'm gonna move beyond this. Let me see if I can, sorry, I feel like I'm still learning how to do this. Okay, new share, okay, I think that's, so I stop it, and then share, go back to the PowerPoint. Okay, and then play from current slide. Okay, so I'm gonna skip all of these. This was my backup plan just in case all of that was not working. But it also, I am happy for Emily to send this presentation to all of you after we're done. And so this will at least give you an opportunity to take a look at what we've shown you for the most part. That's embedded within the slides. So one last thing about Spark, we're actually in the process of evaluating it. We don't want to stop with TF-CBT if we find that it really does help providers engage kids and providers stay on protocol, but most importantly, that it actually improves children's outcomes, then our intention really is to take this much further than TF-CBT. We've already spoken with the developer of PCIT as well as AF-CBT. They're very interested in this, but of course they want to see how effective this is before we start building out other platforms. We've also found that a lot of our Spark providers enjoy using a lot of these activities with kids even when they're not receiving TF-CBT, because a lot of what we've developed is applicable to a wide range of child mental health treatments. So that's the other thing that we've seen through this. All right. Oh, this would be the time, Emily, if you can do poll number 3. Emily, I can't hear anything, so if you can just let me know when to move on.
Sure thing. So it looks like we have about 12 of 25 people who have voted. We want to give a little bit more time for people to put in their answers. And it looks pretty evenly split between strongly agree and agree. So I believe that tools like these would help me engage children in treatment and stay on protocol. So we have about 47% at strongly agree and 53% at agree.
That is very helpful. Great to hear that. Okay. I assume I should advance? Okay, great. Now that I see the poll is gone, I'm taking that as a cue to advance. So I will put myself on mute. I'm sure you're sick of hearing me talk, and let Margaret take over to talk a little bit more about telehealth.
Perfect. And Emily, was there a poll related to telehealth that we were planning on doing as well?
Yes, so we had 2 polls. I can go ahead and put the other 2 polls up really quickly and relaunch those. So let's give a little bit of time. And Margaret, can you see these audience polls right now?
I can, yes.
Awesome. So we have you used telehealth to deliver child mental health treatment? Yes or no? And then the second one, do you use videos, online games, or other technology-based activities when providing treatment to children? So I'll leave those open for a little bit longer. All right, so it looks like most of the participants are answering yes to both questions. We have slightly more on the yes answer on poll question number 2, in using videos, online games, and other technology-based activities.
Okay, perfect. Thank you, Emily. That's really helpful for us to know and provides nice context for where we're moving next, which is talking more broadly about how to use telehealth to provide services to kids. So a little bit of context. Ken briefly mentioned the Trauma Resilience and Recovery Program, which is one of our programs for traumatic injury patients. And I have been a provider on that team for about 3 years now, providing telehealth services to both children and adults who've been through traumatic injury and either go on to develop depression or post-traumatic stress disorder after that. So that is really where I'm coming from and thinking through my tips and tricks. And I'm sure I wish that we had asked in the poll how many of you had started doing telehealth as a result of COVID, but we have heard from many of our community partners that that transition to telehealth has been a real challenge. So what we've tried to do as a team is come together and find common themes and struggles that people have, but we also really want this to be as interactive as it can over virtual platforms. So if you all have questions about telehealth, please start entering those into the chat box, and we will try to field those and address any specific concerns you have. I also have found that one thing that's really helpful with telehealth is talking to other people who've been doing it. So if you guys have things that have worked really well, that are tips or tricks that you use that you think would be helpful to others, we also would welcome those comments in the chat box as well, because I think we can all stand to learn from each other, as this is a relatively new and emerging way of doing treatment. So that's a little bit about me and what I'll be talking about today, but just to give you some context. So the research literature is pretty robust and consistent on telehealth, and video conference and phone-based work tends to be as effective as in-person services. And this is across a range of presenting problems and treatment outcomes. So we find similar levels of patient engagement, we find similar levels of symptom reduction, and this has been true for things like depression, anxiety, substance use, trauma, and the list just keeps growing and growing. So it really does seem like this is a viable way to get people the treatment that they need. It also is true that these findings have been done in both geriatric, adult populations, and child populations. The literature on kids is slightly more mixed because it really depends on their age. And I'm sure some of you, if you're providing services right now to kids in COVID, know some of the struggles of providing telehealth to kids younger than about 6 or 7. I certainly do. I have a patient who's 5 on my caseload and have really made lots of adjustments and changes as a result of moving to telehealth. So I'd be happy to talk more about that as well. Another consistent finding in the research is that patients really like it. One caveat to this is most of this research has been done with people who have selected telehealth services, and we're in this kind of new frontier right now where many of our patients who were coming in person had to transition to telehealth. And with that, I suspect that the ratings of satisfaction and alliance might look a little bit different because you have people who were really used to coming in person into an office, switching to telehealth, and there are some challenges with that for sure. Another consistent finding that's also really rings true for me is that despite all of these research findings that it works, that providers remain kind of concerned about how telehealth works and affects their patients. So I had been doing research at the intersection of technology and mental health for about 5 years and providing in-person services for about 5 years when I made the switch to telehealth. So I went into doing telehealth full well knowing that it works, that there's lots of research to suggest it works. And then I jumped into doing it and I realized it's quite a shift from the perspective of a provider. And I would imagine that that probably resonates with some of you who have recently made this shift as a result of COVID. I was really kind of frustrated sometimes by the technology issues. I didn't really know how to engage people. And what I really encourage providers when I do trainings like this is to kind of fake it till you make it. That the research shows that the more that providers do this, the more comfortable they get and the better their attitudes are towards it. And so I think it's kind of akin to exposure therapy with our patients. I think to some extent we just have to keep doing it until it feels comfortable. And what I do when I have uncomfortable situations or I'm having trouble reading nonverbals or feeling connected with the patient is really leaning back and reassuring myself, okay, we know this works. Research shows that it works even when providers feel like it isn't working, it is. So I try to remind myself of that when things get kind of uncomfortable or I feel like it's not going as smoothly as I'd like, to be able to kind of remind myself that I do have the skills and knowledge to do this, and so do all of you. There are things, though, that are challenging and different about telehealth. So I think it's really important that before you get started doing telehealth, and obviously as we made the transition to COVID, none of us really had the luxury or time to get used to some of these things and take the time to do it. But I say it's never really too late to kind of readjust and change the way that we're doing things. But it's really important that you know the platforms that you're using. So some of this is practicing with colleagues, and I know that that takes extra time, but I've learned in my own work that if I sort of jump into it, I end up spending more time in session and feeling more frustrated than if I'd just taken the upfront time to sort of learn the platform and know what it's like from the patient end, from my end. So we practice as a team using different platforms as both the patient and the provider, so you're able to help them troubleshoot. So we practice on phones and different devices to see what that experience is like, so that you're able to say, okay, if you're having issues or you flipped your camera accidentally, here's where you click on your end. You kind of know what it looks like from the patient end. It's also important that you know the pros and cons of your different platforms. So right now we're in this kind of uncharted territory where we have fewer restrictions than we usually do and can use really any platform. That could change at any time, and we would have to go back to using HIPAA compliant platforms. So it's important to know what the privacy is like on your different platforms. I know really early on in COVID, Zoom had kind of an unfortunate feature where it was recording things without people realizing, and therapy sessions were ending up on the web and things like that. And I think it's important that we know what the security features are like, and in patient-friendly ways explain the pros and cons of different features and platforms to our patients and explain why we're using them. One of the biggest ones that we come up with is certain platforms use different bandwidths. So we use primarily Doxy.me and Video on our team. Doxy.me is a great platform, but it uses tons of bandwidth. So if you're working with someone who doesn't have great service or is in a really rural area, you're gonna have connectivity issues. So we like to sort of know that ahead of time so that we can selectively choose between things. And I would say in this time where restrictions are more relaxed, that if you feel like there are going to be a lot of connectivity issues, or you know something about your patient's connectivity, switch to a lower bandwidth platform like Zoom right now, because one thing that the research also does show is sort of the more technical difficulties that patients have, the more frustrated they get. I'm sure we can all relate to that as providers. It is really frustrating to be 10 minutes into a session or doing trauma narrative with a kid who is really hard to get bought in, and then to lose them because of a technology problem. And related to that, it's really important to build in time to your sessions to troubleshoot connectivity and technical issues. So the way that I do this is really adjusting what I have on the agenda for the session and sort of accepting that treatment might move slightly more slowly than it would in person, and that I might have to take more time to manage things that I didn't expect to. And some of that just helps me manage my own expectations so that I don't feel frustrated and get fed up as I move through. Another thing that we've found just to be critically important is to set firm ground rules for our clients early and to remind them often of these throughout treatment. So we do this in person to some degree, right? We tell people about our cancellation policies or our late arrival policies. All of those things still apply for telehealth, but then there's a whole other host of things that is important that you establish. So I did an intake earlier this week, and the patient answered the phone with no clothes on, in his underwear, outside. And I had wished that I had sent him our list of ground rules before the session to avoid that situation, but obviously it happens sometimes. And I immediately sort of said, hey, we're gonna hang up. It's really important to kind of treat this like you would any other doctor's appointment. If you could please put a shirt on, that would be great. Pants would also be great. So if you could please just hang up and shoot me a message when you're ready, then we can get started. And then went over the rules in a non-punishing way, because I really don't think he intended any harm. I think people are in their home, they feel comfortable, they don't have any expectations for what this looks like. So they needed to kind of jump in and set some of those ground rules for them. So related to that, some of the other ground rules that we set are expectations for TVs being off, decreasing distractions, figuring out where is an ideal place for them to be in their house at the time. And we also want to be flexible with people. We had a provider on our team get all worked up a couple weeks ago because someone was eating during a session, and people are in their home. It's going to look a little bit different. And I think as long as it's not interfering, we can be flexible with people. I've done sessions outside as long as they feel comfortable with their privacy, because that might actually be more private for a lot of people than being in their home. So just being thoughtful about those things. But if you do feel like a behavior is interfering with your ability to do therapy, like there's a TV blasting in the background, or you can tell that they keep checking their phone, I will sometimes up the ante on these rules. So I'll have certain patients that I tell your phone has to be on do not disturb mode for our whole thing, because you struggle to ignore text messages or notifications that come in. And those are things that happen for all of us. Another consideration for telehealth that I think is something that often we don't think about ahead of time until it pops up is planning for safety issues. So as opposed to having someone in your office who, if you find out that they are imminently at risk, you're able to kind of keep them there until you're able to call the appropriate authorities, and you can sort of, to some degree, ensure their safety in the time that they're in your office. That's not true over telehealth. So I'm working with another patient right now who's homeless, and every week he shifts where he does our sessions, and he also has lots of suicidal ideation. So it's critically important that I establish his physical location at the beginning of every session, to ensure that if for whatever reason I need to send emergency services, I know where to do that. And that was a really clear and direct conversation I had with him, where, I said, I just need to know where you are. I need an address for that. And I'm going to ask you at the beginning of every session. But I also have conversations around how, especially for people who were in person with me and then switched to telehealth, how this might be a little bit different. So if for whatever reason I'm in the midst of doing risk assessment and we get disconnected and I can't get back in touch with someone, I would have to call emergency services much more quickly than I might if they're in person. And again, I can kind of keep them there until I can do a thorough assessment. So if we get cut off, I tell people that to just expect that my threshold or bar for engaging others around this might be lower than it was when they were seeing me in person. One of the things that we hear time and time again from providers, and I certainly know from my own work, is that engagement looks different and can be really challenging. And I think sometimes it feels more challenging than it actually is. I think, to go back to that sort of research finding, that patients really tend to find that they like telehealth. I think it feels different for providers. But it is really important that ahead of time you think about what aspects of your intervention or your treatment plan for that day might need to be adjusted. And this is anything from, oh, I was planning on showing them a worksheet and it'd be really helpful for me to see ahead of time how they filled that worksheet out, thinking through how you're going to do those things. So is it going to be sent over email? Are they going to have the capability to share their screen with you, or can you share a screen and then have them write down answers on their own? If they don't have email or those things, how can you find other ways around that? So I've done things where I've had kids show me that they have a piece of notebook paper, and I'm reading them things that I want them to write down as reminders on that paper so that they have some version of what that worksheet would look like. But also thinking through, oh, there's this part of treatment where it's really important that I can see someone's affect. So I might try to make sure they're in a well-lit area during this time, or I might ask them to turn on lights if I'm having trouble seeing, or things like that. So we find that telehealth is to some degree an art of balancing kind of creativity and flexibility while trying to provide evidence-based care and still do what we know works. So I think it's also important to realize that we have neat opportunities, particularly I think for kids, to use this environment shift in creative ways to our advantage. So I do a lot of trauma work, and a big part of that is exposures. And they're really neat ways that you can actually get insight into what someone doing an exposure in their natural environment looks like, and really maybe bringing some of that into session and using that to your benefit. So if you know that a patient's engaging in all sorts of safety behaviors around locking doors or checking lights, you might set up an exposure with them over telehealth where you're seeing what that looks like in their regular environment and working with them to move past that. I also do a lot of child behavior management work, and I find telehealth to be so important because you see what parents' challenges are to doing some of these skills. So I often help them walk me around their house and find like an ideal location for timeout that's both safe and free from distractions. I also will sometimes have them practice skills and realize, oh, there are 50 other siblings or kids in the house who are interrupting positive one-on-one time. So it might not be feasible for this parent to do positive one-on-one time the way that it's intended to be done. How can I get creative and work with them to still meet their needs? So it's a really ecologically valid way of doing treatment where you're seeing what people are up against in their own environment. And then I think going back to sort of knowing your platform, certain platforms allow you to screen share. Unfortunately, others don't. But just the way that Ken was using some of the Spark tools to show you, some of that can be done over telehealth too. So I hate teaching progressive muscle relaxation, but I have a video for kids that I love that I use every single time. And I use screen sharing to be able to kind of share that and keep that piece of treatment that I really like and find helpful in there. And lastly, just some extra considerations. Everything I've said thus far, I think also applies to children, but then I think there are some even more unique challenges to kids. And one thing that I find, and I think this is true in person too, but relying on caregivers to support you. In telehealth, I use my caregivers as like almost a second provider. So I spend a lot of time with them explaining what my needs are and working with them to figure out how we can do that. And that's anything from how are we going to keep the kid in front of the computer or on the phone with me long enough to do something meaningful? What is an ideal space in your house to do this? How are we going to keep siblings out of the room? This is a really averse process in person. I have a treasure box that I bring to sessions for younger kids, and for adolescents, I'll sometimes ask them what they would like as a reward, and it's like getting them a nail polish or it's something like that. But unfortunately, when you're doing telehealth, I can't provide those things, but I work with caregivers to find kind of low cost ways that they can help reinforce, if I feel like that's necessary, kids engaging in services, because we know that sometimes kids don't want to be in therapy and they don't know what to do. So I really coach parents to almost be a second provider and help me in that process. I also think that it's important, again, to that flexibility and creativity with telehealth to figure out what can be adjusted. So I mentioned that I transitioned a 5-year-old patient from in-person services to telehealth at the beginning of COVID. And part of what I had to do was adjust the amount of time that I spent with him in session. He has really struggles with attention to begin with, and then telehealth was just sort of a nightmare when we first started. He would hang up on me, you know, just be running around the house. So half the session would be mom chasing him with the camera. So we adjusted, and I said, I think he can really only handle like 10 minutes of me. So I'm going to spend most of the time with the caregivers, working with them to figure out behavior management, seeing if an older child in the home can provide childcare during that time, so I can do meaningful work with mom and dad during that time. And then I'm going to really figure out what I need that child there for, find ways to reinforce his engagement. But, you know, I went from spending probably 30 minutes a session with him to about 5 minutes a session with him. And he's getting better and it's still working, which is great. But I do think, you know, even with adolescents, staying on video chat for an hour is hard. So if you have the ability and flexibility within your practice to adjust some of that, I think it's okay to adjust it, even if it means you meet with them more frequently than you might have, but just for shorter periods of times. I touched on this, but if caregivers aren't able to reinforce participation, you can find creative ways to do this. So I've gotten to know all of my kids' pets really well. They've gotten to know my pet well. So some of my patients who really like cats, I'll say, okay, if you work with me for 15 minutes, I'll show you my cat. You know, just finding ways to use the environment shift and reinforce things. I do show and tell. I have kids send me links to their favorite video, and I'll screen share that and watch it with them. I have adolescents show me things on Snapchat if that's reinforcing to them, and kind of reserve some time to build rapport and just kind of work with them in creative ways. I also think it's important that we remember that safety and privacy with our kids might look a little different. So if a kid is struggling with their caregivers and is used to kind of having that time alone with you in session, they don't necessarily have that in their home. So I'll work with caregivers and teens to figure out ways to enhance privacy, because a caregiver could always be standing outside their door listening or things like that. So I do encourage the use of headphones, particularly for talking about sensitive things. And obviously caregivers have a right to know everything, but as providers, we all make decisions about what we're going to share with caregivers and what we're not, based on what we think is important. So sometimes I'll have kids wear headphones, and I'll ask questions in a yes or no fashion so that they're able to kind of innocuously answer and still give me important information, but just making sure they're not saying something that's going to get them in big trouble or put them in risk, and also give them enough privacy to continue to do things. So that's all that we prepared for the presentation today. We'd be happy to answer any questions about anything we presented today, but particularly if people have questions or concerns about providing telehealth, we'd be happy to answer those as well. Oh, and please use the chat feature to type in questions as they pop up for you. I'm a therapist, so I can sit with silence for a little, but I will throw out some questions. I know I brought up engagement. What kinds of challenges are you all having with engagement? I see a question. That's a great question about, so there's a question about how do you handle crisis situations as they arise during the course of telehealth. And it's not a super helpful answer, but it really depends on what it is. So if someone, if a child is in risk, it's somewhat easier to deal with because you're able to kind of pull in the caregiver and make sure that they do means reduction and sort of have that conversation. You have sort of an extra set of eyes if there is a sort of stable caregiver around. Um, I've gotten the question a lot about what we do with child abuse and neglect. And obviously, if it comes up, you still report it. Unfortunately, I think over telehealth, it comes up less because often the perpetrators are home there doing with kids, and it's harder to kind of see things like bruises. But we also do get insight into people's houses, and sometimes like neglectful situations will pop up, and you still would kind of report those and follow all of the same structures that you do. We provide telehealth services pretty far from where we are. So I try to educate myself ahead of time on what resources there are in that community for crisis things. So in Charleston County, where we practice, there's mobile crisis, but some of our more rural counties don't have that. So I work with people to say, okay, you know, I am going to have to call 911. This is what that's going to look like. And it's really different than being able to kind of walk a patient over to the hospital or make sure that they get to a hospital. But if it is kids, really relying on caregivers to do what you think is necessary and doing kind of frequent follow up with them.
Sorry, I couldn't find the unmute. I see that we have a couple, there was something under the Q&A piece where Melissa mentioned that it's hard with teens whose only answer is, I don't know, which is a very valid point. It can be a very hard thing to engage with teens over telehealth.
Yeah, and we hear that time and time again that, you know, we all struggle with that in person, but then over telehealth, if they want to hang up, they can hang up, or if they want to walk away, they can, and there's way less that you can do about it. But again, if they have good relationships with caregivers, working with caregivers to find something that's reinforcing, and still remembering that all of the skills that we have in person, we still have. So finding ways to kind of take a step back and build rapport. I think things like sitting with silence don't work quite as well over telehealth because it's hard to know if they're just connectivity issues or what the reason for that is. But so I really spend a lot of time in my telehealth sessions building rapport and establishing trust and being okay with if most of our session was watching some videos and like just trying to figure out the teen or making fun of myself so that they feel more comfortable with me, that's okay. And it might mean that treatment goes more slowly or looks different. And then sometimes I reward teens with getting out of session early if I can do that with the payer or with sort of the structure of the practice that I'm practicing in. So I might say, okay, like you did such a great job today. I really appreciate that you opened up. I know that was hard for you. We have 15 minutes left. How about we just call it? But I know that that's not possible for everyone depending on what your payment structure is.
We had another question that I'm not 100% sure I have my head wrapped around about working with clients and insurance and when and where I need to send any documents. I don't know as a telehealth provider whether that you might know what that person is referring to exactly. Is it insurance documents that they're concerned about, or?
I'm not 100% sure. So we do, I guess, a couple of points around that. DoxyMe, which we use, the version that you have to pay for does allow for teleconsent. So there are ways to get the documents that you need through that, but I know that a lot of people right now are using the free version of Doxyme that doesn't allow that option. Right now, because of COVID, most restrictions are pretty relaxed. That verbal consent is being accepted, and it is just really important that you document clearly everything that you do. So for reimbursement for home-based telehealth right now, insurers want you to put where the patient was when they were receiving telehealth, where you were when you were providing telehealth, who that they have consented to telehealth, what platform you're using, and all of that needs to kind of be documented clearly. We also know right now that we're all kind of flying by the seat of our pants a little bit. Insurance companies have said that they're going to reimburse this, but most people right now are just billing, hoping that some of this will get reimbursed, but not really knowing yet what those reimbursement rates are going to look like. I think there's slightly more clarity now that we're a couple months into this. But really going to each insurance company for each patient and figuring out what is authorized and isn't authorized. And I know that takes a lot of time, but the more that you can sort of note in your notes about how you are doing telehealth, why that decision was made, the more likely you are to get reimbursed at this time. I saw another question in the Q&A about age for kids, and that's a great question. Pre-COVID, I would have said that I wouldn't have really attempted this with a kid much younger than about 7, and that's what the research suggests as well. During COVID, if that's really the only way for a kid to get treatment, I think we are all trying to make it work with kids younger than that. But I do find that finding ways to do kind of more parenting work and using the parent to coach the kids. So doing a lot of parent behavior management with families for kids younger than 6 is helpful, or really like relying on the caregivers sitting there with the kid and like having them sort of teach some of the skills. So teaching the parent how to talk to the kid about emotions or talk about what's going on, or teaching even a parent like behavioral activation for some of our depressed kids and the rationale of all of that. And then just bringing the kid in for specific pieces of that is going to be really helpful. But we know that sometimes caregivers aren't available or not engaged. And then we just do the best that we can, I think, right now.
Oh, there's another. Oh, go ahead.
Yeah. So there's another great question about what to do if a client's acting aggressively towards the caregiver, which is serious enough risk to the caregiver's health or safety. And that's a really tricky situation. And some of it would depend on the age of the kid. If it's an adolescent, I think I would, discontinue what we were doing to try and work with the parents around a safety plan to ensure the kid's safety, but also their own safety. So talking through, is there a room you can go into and lock if this is happening? Is it possible to take away or sort of remove things that the child can hurt you with? Obviously slightly different, but the 5-year-old that I mentioned had pretty severe behavior problems, and during one of our sessions when put in timeout actually punched a hole through his bedroom door, which was not ideal, but does happen. And in that case, I tried to adapt the best that I could to ensure everyone's safety. So we started doing sessions in rooms where parents could lock the door with them in it, but that they were also removing things that he could hurt himself or them with. And that involved pretty serious adjustments. At one point it involved taking a dresser out of the bedroom because he had flipped it during one of our sessions and obviously could really hurt himself or his 2-year-old sibling. So things like that, just really trying to think about what would I do in session. We would make sure if they were in person, I would try to make sure I could leave the room to protect myself or that the caregiver could leave the room. So you still want to try to set up those kinds of scenarios and situations. But I think sort of assessing on a case-by-case basis. And if you decide that something that you're doing in session is leading to that behavior and making it worse, it might mean that you need to discontinue or that telehealth isn't the appropriate level of care. And telehealth isn't the appropriate level of care for everyone. Unfortunately, in COVID, our options are limited. But, you know, we do occasionally say this person, we can't keep them safe, and telehealth isn't the best option.
I'm not seeing any other comments, and I'm sorry that you ended up having to field all of them.
I did want to say, I'll give a couple of moments, but I know that we end it with telehealth, and I know that that's probably really fresh on people's minds right now, but do people have thoughts about how Spark would work in their practice after seeing it? Which of the tools do you think might be most helpful or least helpful? I think it doesn't necessarily have to be questions, but I'd love to see some feedback or comments about that.
Is there a way to connect the app to your computer via an iPad to screen share? Yes, actually, so we created this for providers to use on an iPad, but it's actually a web-based tool. So we have recently we have a little bit, maybe several dozen Spark providers right now, and we have recently done training, much of it being led by Margaret, to teach them how to adapt now that we're in COVID, to show them how to use it over telehealth through screen share. So much like I just showed you all the tools, I did a live demo. That was not a PowerPoint presentation. I actually was on my laptop on the web, and it's not exactly the same. So you're not sitting side by side with a child, having them spin the wheel or having them, choose an activity or keep score or anything like that. But it still can be used in a very interactive way. So yes, there is a way to connect to the app. It's not fully publicly available at this moment, but there are a couple different ways where we could give people access to it. One is through the actual project, where we've recruited 150 providers. So if, for example, you work at a clinic where there might be, 3 or 4 providers or more who might be interested in learning more about the project, then, we do orientations pretty routinely and talk to them about the project. And if people are interested, then we can enroll providers in the use of the Spark toolkit. And we have a variety of incentives. So for example, the clinics actually get to keep the iPad at the end of the project for each provider who participated. So it's a pretty neat project. That's one way to do it. Another way, if you're sort of on your own, or you're the only person in your clinic who is doing TF-CBT, for example, and you just want to, try it out and maybe give us some feedback along the way, then we'd be happy to give you access, give you an account so that you can, learn how to use it, try to use it with some of your clients, and then maybe tell us a little bit about your experience and what you think we can be doing better. You're welcome to just reach directly out to either of us if you'd like after the presentation, and we can just talk to you about it at that point.
I don't see any more questions or comments. So Emily, maybe, I think you had something else to add.
Yes, so thank you so much for that lovely presentation. I will go ahead and share my screen once more, just to give people an opportunity to fill out our survey. So we'd like to thank both of you, Ken and Margaret. The Southeast MHTTC would also like to thank our participants in today's event. We value your feedback and invite you to complete this SAMHSA required survey by either clicking the link provided or by scanning the QR code presented on the slide. Completion of this survey will provide information to our funder and assist us in planning future events just like this one. Afterwards, you will be automatically redirected to an additional set of questions from the Southeast MHTTC regarding the impact of this event on your knowledge and your skills related to your work. Please allow about 5 to 10 seconds for your browser to redirect you to this survey. And for those of you who are interested in receiving a certificate of attendance for today's presentation, one is available for download upon completion of the 2 surveys. So again, I would like to thank everyone for their participation and for their feedback and for their questions. Dr. Ruggiero and Dr. Anton, I'd like to thank both of you for your lovely presentation and for being with us today and answering our questions. Everyone can please visit our website to learn more about our center and our upcoming training opportunities. And that will conclude today's webinar presentation. Thank you so much to everyone.
Thank you. And Emily, just so that you're aware, Melissa sent a Q&A on whether the link is clickable on a phone, so you might want to speak to that.
I am not sure if it is clickable on a phone. I know it is clickable on, I'm going to share it one more time just so that everybody can see. Not sure if it's clickable on the phone. I know that it's clickable on a desktop or a laptop. I would just try to click it on the phone. If you can't, I think that you can screenshot it and either enter it into your browser, or you can copy and paste that link into a browser window and it'll do the same thing. All right. So thank you so much, everyone. Have a lovely holiday weekend. And that will conclude today's presentation.
Thank you.
Thank you both.
Thank you. Have a good one.